focused on improving cancer therapies. He is working on various cancers, including pediatric, young, adult, and adult cancers. He is the recipient of numerous grants from National Institutes of Health and non-profit foundations. Dr. Basha has been recognized for his research at national and international platforms. He received multiple awards, including 4 research presentation awards from the Society of Toxicology, US, and the Best Presentation Award at the International Conference on Drug Discovery and Therapy held in Dubai, UAE. Dr. Basha co-authored around 100 peer-reviewed publications, served as guest editor for 2 journals, and is reviewer for more than 50 scientific journals. He is a member of several scientific societies, including Association of Biotech, that is ABAP, American Association of Cancer Research, American Association of Clinical Oncology, and American Association for Clinical Chemistry, that is AACC Academy, and became fellow of ABAP and AACC. So with this, I invite Dr. Basha to deliver his lecture on cancer history, risk factors, screening, and standard care. Sir.
Thank you, Dr. Malik. Thank you for the introduction. Can you see my screen?
Yeah.
Okay.
Yes.
Thank you all for attending the lecture. I'm going to present some basic stuff because I was told to give a general lecture. That is the reason I do have some research data, but right now I'm going to present some basic information. Depending on the time, I don't mind presenting some of my research. Conflict of interest, as per my institutional guidelines, I need to declare I don't have any conflict. Learning objects of this lecture, I'm going to present some characteristic of cancer, which you might already know. I just wanted to start from the beginning. And also I'm going to present some history of cancer, causes and risk factors, and also few therapeutic options. I'm going to present what will be future in terms of cancer treatment and also importance of cancer screening. So when it comes to cancer facts, globally, there will be 18.1 million cases diagnosed annually and also causing 9.6 million deaths. So it has huge impact globally. And the United States, the new cases per year, especially projected in 2020, we are at the end of 2020 now, is 1.7 million new cases and 0.6 million deaths. When it comes to India, the total cases projected to be diagnosed in 2020 is 1.17 million, that is 11.7 lakhs, and deaths are 0.8 million. So it's like a huge number. When you compare with the United States, that's a developed country, and India is a developing country, among 1.7 million cases, that is almost like 0.53 million more when compared to India, the death is 0.6 million versus in India it is 0.8 million. That shows that the prognosis is poor in India. Today, while we talk, at least 4,500 families in America and 3,200 families in India will get the information from the physicians one of their family members is diagnosed with cancer. So when it comes to cancer, we all know life starts with single cell. After the fertilization, single cell is going to, the zygote is going to divide to form organism. So when the single cell is dividing, obviously if it just divide, what is going to happen is we all will be like balls. Then we will be called a small ball, big ball, that ball, this ball. We don't even have to have names. Why we have names? Because we all have different shapes, different features and everything. That's all coming from not just the division of cells is part of life, but those cells have to differentiate to form tissues, organs, then organism. So in a nutshell, cells have to divide and at the same time they have to be regulated. So the cells have to have a regulated division and then growth. So that's how all bodies are evolved. Unfortunately, in cancer, what is going to happen is cells are going to divide. As you can see here, I'm going to come up with the laser pointer if I can. Okay, so cells are going to divide. When they are divided, and then some cells are going to die and some cells are going to survive. But in cancer cells, what is going to happen is they only know one thing, that is divide, divide, divide. Just like if you see a car that has only accelerator, no brake. So that's what is going to happen in cancer. So because of this division, it's going to become a abnormal growth. That growth is going to lead to a formation of tumor. What is going to cause cancer? This is a big question. Obviously, the answer is very difficult. However, there are certain factors which we already know. Either it could be external factors or internal factors. Internal factors in the sense like epigenetic changes, such as DNA methylation, histone modifications, loss of impeding, those kind of things, or certain kind of mutations caused spontaneously within the cell. External factors such as exposure to carcinogen or exposure to certain kind of radiation or UV light, those kind of things can also lead to certain molecular effects or molecular changes within the cell. If that cell is not going to handle that, then it may lead to certain mutations. That mutations may make the cells to cancerous, that is going to lead to cancer. So there is a popular theory about describing how cancer can happen in cells. It's called two-hit theory. So how these mutations are going to occur and how it is going to lead to cancer. Because you might be knowing, and we all know that family history is also going to cause certain cancers. In this case, if the parents are both healthy in a non-hereditary cancer type, if parents are both healthy, offspring is going to get both healthy chromosomes. So there is no hit at all at the time of birth. During the lifespan, these chromosomes, one of the chromosomes may get a hit in the sense that is mutation within the chromosome. I mean the genes actually, in one of the chromosomes. So if that is going to happen means at this moment it's not going to be a cancerous cell. It's not going to cause cancer. It has to wait for second hit to happen in the second chromosome. Then only this cell will convert into cancerous cell and then it's going to cause cancer. So two hits have to satisfy in a paired chromosomes so that can lead to cancer. In hereditary cancer type, one of the parent will pass a defective chromosome. It means the chromosome which has already mutated gene into it, that will be coming from one of the parents. So first hit is already happened at the time of birth. After that, during the lifespan, it can happen second hit that's going to be in the other chromosome. Then the cell is going to become cancerous cell and that's going to cause cancer. So this theory is still acceptable even though it is proposed long back. So still, people are believing that this two-hit theory is very much acceptable. When it comes to history, one of the question is, how old is this disease? The best answer could be, it could be as old as human life. However, we only know, if it is in the past or not, depending on some kind of documentation. That's how we will know about history. It's not something in a paleontology you go back and dig and know there is something is there. When it comes to diseases and stuff, we only gonna know because of documentation. There is some documentation from 4000 BC, at least people know about the disease. The fair documentation coming from 2500 BC from Egyptian texts. It's called medical document. In this medical document, they described about the disease, a bulging tumor in breast, a ball of wrapping. The most important thing is treatment is none. So people know about this one, at least from Egyptian text. We know from 2500 BC, they know about breast cancer. The reason for that one is maybe the people might be dying with pancreatic cancer and some of prostate cancer or cancers. However, at the time, there is no diagnostic tool to detect and see inside the body. No MRI, no ultrasound, no imaging technologies at that time. They can only physically feel and determine there is a disease. So because of that reason, at that moment, people know about only breast cancer. So once you know cancer, how to treat this one? There are no treatment methods at that time other than just trying to remove the tumor from the body. So they were using like some methods at that time. If we try to know now, it may look brutal, but that's what the methods they were using for all kind of this, even in the fights. The methods they were using for all kind of this, even in the fights at that time. They are fighting with the swords. If you look into the old movies, how the wars are going to happen between kingdoms and all this. At that time also they are using certain kind of treatment methods which we may feel now, oh, how these people are doing it. But they're doing it scientifically at that time. They were using fire to burn the area so that can be, that tumor can be removed, or using acid again to burn out the area, or leather belts. When leather belts are tied to the area, they are going to narrow down and stop the vasculature or blood supply. Once the blood supply is stopped, it's going to become paralyzed, and then that area is going to be disconnected from the body. That's the whole idea. However, in these cases, the danger is it may lead to wounds and it may lead to infections that may lead to even, sometimes it could be even deadly. First time in 1890, William Stewart is a surgeon. He conducted radial mastectomy using these tools at that time, just like the tools we use in a lab, because you are in zoology in laboratory, will be using like scalpels and smart scissors to do like dissections. So those kind of tools at that time, this surgeon used to remove breast, which is cancerous. After that, radium is discovered. After radium is discovered, it is used in therapy. As you know, when radium is exposed to cells, it's going to cause DNA damage. One thing difference between normal cells and cancer cells is, in cancer cells, DNA repair mechanism is not very active as normal cells. So that is the reason, one of the reasons why these cells mutate and become cancerous. Because DNA repair this mechanism is not active when DNA is damaged due to radiation, those cells are going to die. Even though healthy cells are exposed to radiation, because they have better DNA repair mechanism so that they can repair. However, now we know when radiation is exposed to areas that may cause secondary cancers. That is the reason now radium usage is very much reduced. Even if they have to use that one, they use like sophisticated instrument so that they can actually expose limited dose or longer periods, certain kind of optimization, using a certain kind of optimization, and especially in a focused area. Just to expose that area. At that time, at least initially, radiation was working to choose certain solid tumors, let's say breast cancer or some other cancers. Then World War II happened. When World War II happened, at that moment the main issue is not breast cancer. At that time, the main issue is leukemia. At that time, people were worried about people dying with leukemia. During World War, as you all know the history, chemical weapons were used. One of the main chemical was mustard gas. At that time, from America, from Yale University, they sent Goodman and Gilman. You might be knowing about Goodman and Gilman because they wrote a lot of books. I believe Physiology is one of the books which is very popular in India. I also read that one when I was in India. So these two physicians went to treat military people who are exposed to mustard gas. They observed some interesting thing. What they observed is, when people are exposed to mustard gas, their WBC are disseminated. Then they thought that maybe we can use this one as a therapeutic option to treat leukemia. So that one was developed as a chemotherapy. So giving mustard gas derivatives to treat leukemia. With the help of radiation and with the help of chemotherapy, there are some patients recovering from the cancer. The reason is, at that time, as I mentioned, there are no diagnostic tools. When patients are diagnosed with cancer, it's already at advanced stage. So those people are not surviving more than few months. After these treatments are at least given, people are surviving longer. So there are some successes and people are surviving longer. With that, everybody believed that we are going to win war on cancer. So they went to President Nixon and he signed a National Cancer Act in 70s, assuming that we are going to win the cancer maybe within a decade. Unfortunately, it's a never-ending war. We are not able to win the war even now. Reasons are different reasons. Main reasons are, as we think, cancer is not contained to the place where it is originated. More sites are involved. So many people are diagnosed when the cancer is moved from one site to other site, moving or spreading disease from one site to other site is called metastasis. When the cancer is originated, that place is called primary site, then it may move to secondary site. So that is called secondary tumors or metastatic tumors. Those tumors are more difficult to treat. For example, if the cancer is originated in breast, if it's moved to bone, if it's moved to brain, it moved to liver, it's very difficult to treat because those organs are even more sensitive and difficult to treat. And also, other thing is, when cancer is treated, there's no guarantee cancer is going to be gone. It can come back. It's called relapse. So disease can come back after the initial treatment. Because of this reason, physicians always keep like first line treatment, second line treatment, third line treatment. Just like infection, if the cells are resistant, they are going to develop resistance with the first line treatment. If the cancer come back, that treatment is not going to work. They have to use like more cytotoxic treatment again to treat when the cancer is relapsed. Resistance to treatment is another issue. Most of the cancers, they want to survive. Some of them are very aggressive cancers. They grow very fast and they also develop resistance to treatment. Because of that reason, it is very difficult to treat and prognosis is going to be poor if the tumors develop resistance. Because of all these reasons, it's more than complex and we are still working on how to handle this cancer. And a tumor means always, we don't have to worry. Sometimes it could be non-malignant. Any kind of bulging or lump or growth is called tumor. However, not necessarily all those could be cancerous tumors. So when there is a lump or tumor, physicians always go for biopsy. When the biopsy is conducted, when the cells are examined under a microscope, then the pathologist will give the report if it is a malignant tumor or non-malignant tumor. And again, in the malignant tumor, it could be either primary or secondary. The secondary tumor is going to be formed when the tumor cells enter into the circulation and they go to the different area, different site, and where they are going to settle. So, for example, in metastasis case, metastasis, as I mentioned, spreading from one organ to other organ, that is basically, it will be either near organ or distant organ. Once it is spread to other organs, it's very difficult to treat. Because of that reason, most of the deaths, more than 80% of cancer deaths are due to metastasis, not necessarily due to primary cancer. In cancer, once it is treated, especially in leukemia kind of non-solid cancer cases, it is determined by minimum residual disease. Minimum residual disease means after the treatment, how much cancer cells are still remaining in the body. So that's what is determined minimum residual disease. If the cells are less, that's called MRD is less, then the prognosis is very high and chances of relapse is very less. If MRD is high, it means the chances for relapse is very high and also the prognosis is very poor. If the MRD is low, the prognosis is very high. So that's the difference between MRD and relationship between MRD and cancer survival. For example, in colon cancer, if the cancer is originating in colon, it can first spread to liver and then it can spread to lung. So once it is going, it's spread to lung means it's really at advanced stage, and then it is very difficult to treat. And how cancer is determined? Cancer is determined using imaging technology. It could be either CT scan or MRI or PET scan. In PET scan, there is a dye. It is going to be used to detect a high utilization of glucose. It's called FDG, fluorodeoxyglucose. When this dye is used in imaging, you can see here with high activity. It means the cells are very active here. So it should be supposed to be like this, but it has high activity here. It means cancer is spread in all these places. However, you should have seen here, the brain is also showing a lot of color. It doesn't mean this patient has brain cancer because of two reasons. Reason one is, if cancer is spread all over like this, the patient should have not even survived to come to clinic. He should have died long back. The second reason is, as we know, all our body is controlled by brain. It needs lots of glucose utilization. Because of that reason, the activity is showing high here. However, this patient doesn't have brain tumor, but these areas, the other areas other than brain, they are showing some kind of lesions. So why it is complicated to track cancer? Why it is not detected early? There is a notion in cancer: early detection is life. If the cancer is detected early, especially if it is in situ means inside, wherever it is formed, it's just there. It's not even locally invasive or metastatic. If it is not metastatic, it's easy to treat, and also the chance of relapse are also very low. So when the cells enter into the blood vessel, it's called intravasation. When it come out of the blood vessel, it's called extravasation. So from the tumor, cells enter into the blood vessel, and then when they find a favorite site where they can grow, they will come out of the blood vessel. Once they come out of the blood vessel, they are going to proliferate. While they are proliferating, some of the cells may die, even though they are cancerous cells, but still they also die. They are not like 100% going to survive. But some of them, the surviving cells, sometimes they go into dormancy because they wanted to utilize all the resources so that they can grow faster. Before they go to the fast proliferation stage, they will undergo dormancy. They want to just pool resources. They want to gather more and more so that they can grow better. So because of this dormant period, it is very difficult to detect the cancer. So during this dormant period, cells will be dividing. Obviously, some cells might be dying, but still they are in a dormancy. However, after a certain period, once they form some kind of group, then they will recruit blood vessels. Once blood vessels are recruited, then they will get lots of nutrients and all this. Then it will grow quickly. At this stage, only clinically it is detectable. But by the time it reaches here, it may already started to spread to other organs. That is the case. It's going to be very difficult to treat if it goes to other organs and metastasis is already initiated. When it comes to therapy, if you see in normal scenario, these are normal cells. In normal cells, cells do have functional activity for cell survival because the mechanisms within the cell to survive, they are all active. Same time, cell death mechanisms like apoptotic mechanisms are also active in the cell, in the normal cells. Because of that reason, each cell has kind of a life period. If you look into the blood cells, that's why nowadays, instead of measuring blood glucose, they are measuring A1C because that is going to be coming from blood cells, RBC. So because of that, you will get like 90 days average. So some cells have some kind of lifespan. So cells have to die after some time. Because of that reason, both survival mechanisms as well as apoptotic mechanisms are balanced in normal cells. When it comes to malignant cells, the survival mechanisms are really heavy, but the cell death mechanisms are almost nil, or very, very little. Because of this imbalance, it's going to shift survival of cancer cells longer and longer. When it comes to treatment, what is the best option? Whether we should suppress these survival activities or we should trigger or stimulate or increase cell death mechanisms. But the best option is to do both. In that way, we can actually address cancer cells to be eliminated from the body quickly. So most of the cytotoxic cells, whatever used in cancer therapy, typically do both. They will affect or suppress survival mechanisms. Same times they will increase apoptotic mechanisms or cell cycle arrest mechanisms. So when it comes to chemotherapy, the objective of chemotherapy is to get remission. This is the word I want to introduce in cancer. Typically in cancer, they don't use the word cure. Cure means you have some disease, I give the treatment, you are completely cured. But in cancer, typically, that's why I'm using the word typically, they don't use the word cure, but they use the word rather remission. Meaning for remission is there is no detectable disease. So basically the physician is declaring, you might have cancer, but I am not able to detect at this moment. So you are at remission. Sometimes complete remission is not possible. For example, especially in metastatic cancer, if the disease is spread to multiple organs, even though they give chemotherapy or radiation therapy and surgical resection and all those things, it is very difficult to remove all tumors from all organs. At this time, they only can say, okay, you are at partial remission. Because there are some pros and cons. They don't want to give treatment for years and years. If the tumor is not responding, they have to stop at some point because there's some also cause like side effects. So that is the reason, or at complete remission. It depends on case by case, what kind of cancer it is, when it is diagnosed, and all those things. Other thing is when the chemotherapy is given, the other objective is to get either partial or complete remission and also control the cancer cell growth and also stop spreading to other areas. That's the reason if the cancer is detected early, it can be stopped from spreading to other areas. That is the reason we always call in notion early detection is life. When even partial remission is not possible, if the disease is really advanced stage, there is nothing they can do. At that time, the only option is palliative care. In this care, the treatment is given to ease the symptoms. If patient has pain, maybe given like some painkiller so that he don't feel pain. Other than that, there is no cytotoxic agents or no chemotherapy, no radiation given at this level. Chemotherapy types are actually two types. One is adjuvant therapy, other one is neoadjuvant therapy. In adjuvant therapy, it is called, whenever there is a cancer, especially in solid cancers, I'm not talking about leukemia. In leukemia, there is only one option, is either chemotherapy and radiation therapy to get rid of chemotherapy only. But when it comes to solid cancers, if there is a tumor, surgical resection is the best option when it is surgically removable. After it is surgically removed, then it will be followed by either chemotherapy or radiation therapy and chemotherapy. So that therapy is called adjuvant therapy. Adjuvant therapy is the therapy followed by surgery. And for example, in breast cancer, if the breast cancer is only like 2 centimeters or less, it's only they require like chemotherapy after the tumor is surgically removed. If it is bigger than 2 centimeters, it depends on the case scenario as well, then both chemotherapy as well as radiation therapy is given. For prostate cancer, also depending on the tumor size and also depending on the staging of the tumor, the physician is going to come up with a plan, either chemotherapy or chemotherapy plus radiation therapy. And in pancreatic cancer, colorectal, everything is pretty much same way. Neoadjuvant therapy is a therapy where chemotherapy is given before the surgery. For example, if the surgeon cannot see clear layers to remove tumor, at that time this chemotherapy is started early so that it can shrink, so that he can see the layers, he or she can see the layers and that can be surgically resected. The other option is, the other scenario is when cancer is spread all over, like for example stage 4 breast cancer or advanced glioblastoma, where it is spread to all organs and there is no way they can actually surgically remove. At that time, the only option is neoadjuvant therapy. So anti-cancer agents are several types. One of them is cytotoxic agents or hormonal therapy agents. For example, if the hormones are involved in cancer, then hormonal therapy agents are given. And also targeted agents, if we know what is causing this cancer, then it's usually targeted the agents. For example, in HER2 positive cancer, breast cancer, then herceptin is given to target HER2 so that that the receptor is not active, it cannot make cells to proliferate. In hormonal therapy, also, for example, tamoxifen is a agent given to suppress hormones so that they can it actually going to go and bind the places. I think I may have an example for that one. Bind the places where hormone are going to come and bind. So it can stop hormones to bind to the cell and make cells to proliferate. So these are the therapies popularly used. Nowadays, immunomodulating agents are getting popular because it's always surprise to everybody that why our defense system, that is like immune system, is not working against cancer. How it is allowing cancer cells to grow? Cancer cells, they use some certain mechanisms to escape this our defense system. So now there are certain techniques used, that certain chemicals candidates are used to stop that escape mechanism so that immune system can recognize cancer cells and it can kill cancer cells. It is still in trial. Some of them are already getting promising results. Some of them are still needs lots of optimization. Other agents like cytotoxic agents or alkalizing agents, it could be organizers, it could be topoisomerase inhibitors. I'm not going to talk all of these things because I was told just to give like basic information. Other anti-cancer agents are, it could be anti-metabolites or antibiotics. I also worked on one of these, mithramycin, it's also an antibiotic. And the platinum-based reagents, you might have heard about cisplatin, carboplatin, and oxaliplatin. And also certain miscellaneous agents like aspartate enzymes, they are also used for cancer treatment. So this slide is to summarize what are the agents used and what are their targets, and how it's going to help cancer cells to die. So other therapeutic options are like targeted therapies. If the cancer shows some at that moment, if you have an agent to suppress that marker, then it's usually like targeted therapies. There are EGFR inhibitors and also targeting like vasculature, VEGF signaling, and those kind of things are very much in clinical trials now. And immunotherapy, as I mentioned before, how we can induce immune response so that they can kill cancer cells. And for immunotherapy, there are several agents are used, a monoclonal antibody and also immune check inhibitors. They are actually now getting a lot of momentum now, and also vaccines and other non-specific agents. And other types of for cancer treatment is to target circulating tumor cells, because the cancer cells are going to enter circulation to go for metastasis. When we are treating, using like cytotoxic agents, sometimes they may miss in circulation. So how to target those cells? That is one of the question always rise. So that sometimes it's easy. Some cells can be easily targeted because when the cytotoxics are given through infusion, they are giving like IV. So they are, it is easy to kill, but sometimes they may escape. So there are certain novel technologies now used to capture this or trap these circulating tumor cells. One of the researchers next to our place, it's in Arlington in Texas, he's using called a biotrapper. So he's going to implant biodegradable trap in blood vessels, not in blood vessels because it's going to block blood vessels in certain areas. What it does is it actually attracts cancer cells inside using some kind of chemokine mechanism. Similarly, how it is going to metastasize, why cells are metastasizing in certain areas, because it's going to be because of some certain kind of attraction. Similar attraction is going to create in the trap. So cells are going to enter because it's not an organ for them to grow. There is no conditions there. It can only attract, then it's going to make them to die. So there are certain novel things that are happening now. And also one of the option is when you kill normal cancer cells, if any of the progenitor cells or stem cells escape from that treatment, they may grow quickly. Because of that reason, when you use like conventional cancer therapy, there may be a possibility for the stem cells to escape from this cytotoxic therapy. Because of that reason, there are certain methodologies are going on, so strategies are going on to exclusively target these stem cells as well, so that they don't escape from this routine or traditional cancer therapy. Nanotechnology is a popular therapeutic option these days, using like small, like metallic things, like copper particles or nickel particles. There are certain things that are used in using like nanomedicine, and also these kind of nanotechnology strategies. They are not necessarily just not only using certain things to kill cancer cells, but they are also used as drug delivery mechanisms, so delivery options. For example, if a certain marker is exposed on cancer cells, you can use nanotechnology to deliver your therapeutic drug directly to that one. For example, it has a receptor, you create a ligand, or if it is a ligand, you create a receptor, so that it can go and attach there and deliver the drug. So drug delivery in delivery also, the nanotechnology is really getting popular these days. So as an example for cancer therapy, I'm showing for breast cancer, because this is a serious cancer not only in America and also in India. When it comes to numbers, annually 1.6 lakh new cases are diagnosed in India, about 2.8 lakhs in America. There are 87,000 deaths are going to cause in India due to breast cancer, about 48,000 deaths in America. So it's a huge impact is going to happen in both countries. But again, if you see in numbers, out of 1.6, 87, it means more than 50% deaths are happening in India. But when it comes to America, it's not even like 20%. So that is the reason we need to be more aware of what can affect anybody. So the awareness is really important. For breast cancer, the chemotherapeutic options are several drugs. Actually, it is very well studied cancer. Anthracyclines like doxorubicin, epirubicin, they are all drugs given initially, and also Taxol. They are all given depending on the stage. If it is like initial stages, these treatments are given. If it is advanced stage, again there is different kind of regimens they use. That's what they call as a regimen. Sometimes they don't give single drug; they give like multiple drugs. That's why some treatments cost like 6 cycles. Some even go like 12 cycles. Some of them even go even longer. So depending on the type of cancer and also the size of the tumor at the time of detection, radiation therapy is also used for breast cancer. When it comes to radiation therapy, initially it was used like basic radiation therapy, but nowadays there are lots of advanced options available, including 3D confocal conformal radiotherapy. So all these sophisticated units are used to specifically release this or expose radiation only to the area where it is needed. However, the problem with radiation is, as I mentioned before, if surrounding areas are exposed to radiation, then it is that areas may mutate eventually and cause cancer. And also the areas where it is exposed, that may also cause like secondary cancers. Because if the mutation is going to happen, that mutation can lead to anything. That is one of the problems. When it comes to, because in breast cancer, typically it is like, most of the time it is like either it could be positive to estrogen or progesterone, or it could be positive to HER2, or it could be nothing. It's called triple negative. It doesn't have estrogens or progesterones or HER2. So if nothing is shown, it's even difficult to treat. In HER2 positive cases, initially it's given like cytotoxic agents to kill cancer cells. After that, Herceptin or some drugs just to target HER2. In that way, the cancer will not come back. But in triple negative cancer, it is very difficult to treat because there's no target there. That's what's called triple negative. The only option is giving like cytotoxic agents. That is, and moreover, this cancer is very aggressive. It grows very quickly. It will go to stages like stage 4, maybe within 3-4 years. So that is the most difficult thing to treat. So this is what I told about hormone therapy. In If the breast cancer is because of this hormones, estrogen and progesterone are making these cells to proliferate and grow bigger and become cancerous cells, then tamoxifen is given after the surgery and after the adjuvant therapy. Then it is in tablet form, so it's given like for years, maybe 5 years almost, depending on the stage of the cancer. So how this drug works is, this is cancer cells. It will have sites for these hormones to come and bind so that they can make this cell to grow uncontrollably. Once this drug is given, this drug is more competitive. It's going to have more competitive capacity than these hormones. It's going to come and bind in the exactly sites where estrogen or progesterone can bind. Because this is going to bind here, so there is no space for these hormones to come and bind. Because of that reason, they cannot bind, so they cannot make these cells to grow. And when it comes to targeted therapy, if it is HER2 positive, Herceptin is a very popular drug. Now, I believe it is out of generic might be available now. 5 years back, the generic is not available, it's branded. It was costing, as far as I know, 2 lakhs rupees for each dose. And patients require, I believe, 26 doses. It means it's going to cost 52 lakhs to take this entire dose for the patients who are like HER2 positive. And there are other drugs also working in the same nature. The other one is lepatinib. It's actually a tyrosine kinase inhibitor. It's working in a different side, different mechanism, but still it's going to help HER2 positive patients. There was a clinical trial which is conducted to see whether Herceptin alone or lepatinib alone or combination, which one is better. I believe these results are published in New England Journal of Medicine, showing that the combination is better than individual drugs. However, both drugs are showing very good efficacy. However, the combination is much better than single drug. And when it comes to risk factor, what are the main risk factors for cancer? There are several. One of them is age. Aged people are more prone to get this disease, are more vulnerable to get this disease. As we know, during the senescence or aging process, mutations are going to happen. Those mutations can even lead to cancer. And the other one is air pollution, alcohol intake, and chemicals. So we call it as carcinogens. So some chemicals can cause cells to mutate and become cancerous. Those are called carcinogens. And also family history. Some of the genes that are transmitted from parents might lead to cancer, and genetic susceptibility. For example, there was an article recently came why elephants are not getting cancer or less cancer. I think they have tumor suppressor genes. P53 genes are highly active in those animals. Because of that reason, the chances of getting cancer is low. Tobacco intake. This is biggest problem in India. That is actually, if you see the top 10 cancers or 5 cancers in India, one of them is actually oral cancer. Oral cancer is, tobacco is one of the reasons for this oral cancer. And also UV radiation. UV radiation, especially the Indians and African Americans, I believe they are, because of their skin, the penetration is low. But when it comes to Caucasians, the penetration into skin is very high. That's the reason they always use sunscreen, lotions, and all this. Otherwise, it's going to cause them, cancer. And cancer screening. So screening means checking the body for cancer before the onset of symptoms. This screening is really important. Always prevention is better than cure. So to prevent the cancer or even the cancer to go into effect. Excuse me. So there are opportunities now to screen several cancers. For example, for breast cancer, mammograms are available in many cities now, so it's going to give a better idea. They also say self-examination. Sometimes self-examination may not give a better result. It may be even too late to do like a physical testing to find out. Mammograms are going to give a better idea even before that. Other one is like cervical cancer. It can be prevented if annual tests are done for women, and pap smear tests. It will tell is there any symptoms for cervical cancer. And colonoscopy is recommended for the people who are above 50 years here. So everybody above 50 years, when they go for annual exams, physicals for the physician's office, they are required to get this colonoscopy. That will actually prevent people getting from colorectal cancer. Because of colorectal cancer, especially, it's going to take like 15 to 20 years to develop. If it is detected at the time of non-malignant stage, for example, when it is formed, it's called polyp. It is still non-malignant stage. At that time, if it is detected during colonoscopy, the physician will just remove that one out, and they will send for examination. If it is already malignant, then the treatment will be started. Typically, polyps are non-malignant, so so at that time, once polyp is removed, it cannot convert into cancer. So it's basically prevention, not to become cancerous cell. And also lung testing, low-dose computed tomography can detect. It all depends on high-risk people who are highly, taking tobacco, smoking, and all those things. So those people can be screened for this LDCT to see if there are signs of lung cancer. Any cancer, if it is detected early, the chances of prognosis is very high. And there are also screening tests for bladder cancer, oral, skin, pancreatic, prostate, thyroid cancers. However, the above cancers I mentioned here, there is huge data to support screening mechanisms are very effective for these cancers. And the outstanding issues when it comes to developing countries, number one is awareness. People don't take serious, I need to go for screening. Unless I'm sick, I don't have to go to clinic or hospital. So that is not a good strategy. Of course, there are certain issues like affordability, insurance, cost, and those things. But again, when it comes to health, before even there is some sign going to come, it is very important to go for screening. And also enthusiasm, seriousness. People may not be that much serious. Okay, I am good. Maybe my neighbor is getting disease or my family member is getting disease, but I am not necessarily going to get. I am good. So we don't want to feel ourselves like whatever we are not. Nobody is spare. Anybody can get any kind of disease. So we need to be ready for any kind of these things. And also facilities. Some places, yes. Rural areas, facilities is a big issue. But however, I believe in majority of bigger cities are having this kind of thing, and some states do have. For example, in Andhra Pradesh, they have like Arogyasri, where state government is going to cover the cost of this kind of screening. That's one way preventing people getting into lethal diseases. Other than that, the most important thing is the stigma and sharing information. If somebody gets cancer, they feel like, they feel stigma. They don't want to share even with their family members. They're not comfortable. You don't have to feel that way because it's a disease. Anybody can get it. We really need to be prepared for these kind of situations. And if it comes to future perspectives, when you say cancer, not necessarily cancer, all cancers are the same. Even within same cancer, in breast cancer, as I mentioned, there are several types. There are certain subgroups. So prognosis is not same when you look into different subgroups of cancer. So the focus to find treatment is depending on the specific subgroup, not necessarily it's in general, because we know now cancer is heterogeneous. To accomplish better prognosis, nowadays combination treatments are used, not necessarily just one. We can use targeted therapy as well as cytotoxic therapy. We can also use immunotherapy as well as cytotoxic therapy. So these kind of things, combination therapies in certain cancers might show certain markers which are responsible for this particular cancer. Then if you can target that one, maybe it's better than just giving general therapy. And also, but if you combine all these things, it becomes like a personalized or transition therapy. And again, genetic testing. So nowadays, people are recommending genetic testing to make sure anybody is carrying vulnerable genes or the genes that can prevent cancer are maybe low. If the cancer suppressing genes are low, then the chance of getting cancer is high. Where these mutations are there. Some people don't try to go to this genetic testing. It's like we don't want to get what my future is. But again, it may not give like full information, but sometimes it's really helpful to have this genetic testing. Actually, genetic testing is mandated for certain kind of cancers. Then only they are able to treat it. And taking care of orphan diseases. Certain cases, cancer cases are very low. If the cancer cases are very low, industries don't pay attention on those cancers for developing treatment because it's not beneficial for them. At that time, the government and non-profit organizations should step in to work on those orphan diseases. Obviously, prevention is better than cure, so screening is really important. When it comes to future cancer, nowadays the National Cancer Institute started a new initiative. It is called Molecular Analysis for Therapy. So in this clinical trial, because all clinics or all hospitals might not have facilities or resources to treat rare cancers where the molecular analysis is really important. In those cases, I believe I have a slide. Yeah. So in this case, what they do is they take sample from the patient and they do like a molecular analysis, doing like second next generation sequencing or molecular profiling. Then they will find out what kind of mutations they have, what are the targeted things that can be targeted for therapy. Then they actually have certain compounds or candidates, whether they are already approved or under investigation. We call it as investigational agents. Either one of them can be used to particularly target the particular mutation or particular gene or particular marker. Because of that reason, they will be able to treat those patients. Even though we don't know its prognosis, they might not live longer, but at least it's going to help to some extent to length, to increase their lifespan. In summary, cancer is a complex disease. Metastasis is the one which is responsible for majority of cancer-related deaths because it's going to spread to organs which are very sensitive to treat or which are difficult to treat either way. To handle this heterogeneous cancer, multimodality treatment options are used now, whether it is immunotherapy or not a traditional conventional therapy anymore. It's like precision medicine now. That's what it's used now. And also new mechanisms such as immunotherapy, certain kind of vaccines, especially for example, vaccine was HPV vaccine. This is in America at least people are taking now. I don't know about India. If HPV vaccine is given to children who are like 12 to 14 years old, some of the cancers can be prevented when they grow. Infection related is definitely better. If you look into the statistics, in 1975 there are about 400 cases per 100,000 population are diagnosed in worldwide, and deaths are like 199. That is, the prognosis is like about 50%. When it comes to 2007, the number of cases are increased to 461. This is not just because the cases are increased. I believe it is purely because of the diagnostic possibility or feasibility is increased. People are knowing more and more about this cancer awareness or whatever the reasons. Because of more diagnosis, the cancer numbers are gone up here, but number of deaths wise, it's actually decreased. 50 to 68 means it's almost like 40% increase in comes to survival. In 2015 data shows the number of cases are 440, about 439, and deaths are 163. So it's basically decreasing. So it's a very good sign if you look into the data over 15 and 9, so 24 years. The cancer cell rate is decreased by 26%. This is everything looks good. Still, we have some outstanding issues. When you count here how many people are surviving, yes, number of survivals are gone up, but what is the quality of the life? For example, if you want to get a blessing from elders, if they give you a blessing, may God give you a long life. Do you think it's a blessing? I don't think it's a blessing. If they tell you, if they bless you, may God bless you with long, healthy life, that's real blessing. Because not leading life or living is not important. Quality of life is more important. These cancer survivors are having like very bad lives to some extent. So patients are surviving, but they have like long-term side effects. So now we need to focus on how we can achieve this even better than this. This number may even need even better number. But at the same time, people should have quality life with less side effects. That's what really we need to focus on. And also the cancers, orphan diseases, as I mentioned, those need to be really focused because life is life for anyone. Because just not it is getting enough people, enough business means we cannot ignore them. And also disparities. Certain ethnic populations or races, they are actually having poor prognosis. Even people under tremendous stress, they are showing like poor prognosis. So that is the reason now the research on health disparities also getting more and more popular in America, and even everywhere we need to focus on this one. Obviously, now the focus is to less toxic drugs and more effective, especially targeting like subgroups. Not like any cancer cannot be treated as one cancer, not anymore. It is like everything is different because of heterogeneous nature of cancer. So this is all about introduction. If you want me to stop, I will just stop here. I would like to thank audience as well as organizers, and I will be happy to take any questions. I also have some research data, but it all depends on you. If you want me to present, I will present, or I will be happy to take questions now.
Dr. Basha, you can show your research thing also. It will be better, and the students will definitely like it.
Sure. You are seeing my screen, right? Slides?
Yes.
Okay. So this is the research I have done on Ewing sarcoma. This is the reason why I wanted to present this one. This is one of the orphan disease. The number of cases are very low for this one, and it is going to affect mostly young adults. So I don't know whether people are knowing about this certain age. People, little bit older than children, but little bit, younger than old people. So typically people between like 12 years and also like, below like 39 years, it depends on the definition. Sometimes they consider only until 32 years. So this population is called young adolescents. In this population, this cancer is very high. And again, if you shoot the prognosis, it looks high. If you see here, 70%, it is only localized. But majority of cases, it's very difficult to identify this cancer in this stage. Most of the cancers are diagnosed in metastatic stage. That is 30% the prognosis. Only 30% people will survive 5 years. Other people are going to die less than 5 years. One interesting thing in this cancer is most of the patients, more than 85% of these patients express a protein, EWS51. It's a fusion protein. So the idea now is, how about if you target this protein, is it going to increase the therapeutic efficacy? The standard approach at this moment is, again, it's a multidisciplinary approach. The standard therapy, there are like 4 drugs, actually 5 drugs they use: vincristine, doxorubicin, cyclophosphamide, isophosphamide etoposide. And stem cell transplant is still under investigation, but it's giving some promising results now. Problem is, all of these drugs has to be given like high doses to these patients. It's going to cause lots of side effects, especially cardiomyopathy, heart raises problems, nephrotoxicity, and also it can also cause secondary malignancy because it's given radiation as well as chemotherapy. So obviously people are searching for new drugs. What can be used, especially to target this fusion protein? Groher et al. I met this person. He's a great scientist. What he did was he screened several compounds to target this EWS51. He screened like 50,000 compounds using high throughput screening, and then he found out mitramycin is working very well. It is going to inhibit EWS51 very well. So it's a very specific drug for specific marker. And he generated some data. Then they went for a clinical trial. In this clinical trial, mitramycin is used for the children and also adults with solid tumors for Ewing sarcoma. Unfortunately, this trial has to be terminated. One of the reasons is the dose required, this mitramycin dose required to inhibit this protein is high, and because of that reason, they are getting lots of side effects and toxicity. So we don't want to create a situation where operation success but patient died. That's not what we need. There is always a notion in medical treatment. Patient can die due to disease but not due to treatment. Because of that reason, that clinical trial is stopped. So my laboratory hypothesis is inventing new agents for cancer treatment is important. However, enhancing the efficacy of current standard care and reducing side effects is extremely important. That's what I believe on. Believing on that one, we hypothesized that mitramycin can sensitize Ewing sarcoma cells to standard chemotherapy agents and enhance anti-peripheral efficacy. So in the clinical trial, what they tried was single agent, just mitramycin alone they tried for cancer therapy. However, our hypothesis is, how about if we combine mitramycin alongside standard care, that is whatever the drugs I showed you, 5 drugs. If we can combine, probably it will give better results. To do that, initially we need to try in preclinical studies. Preclinical studies means using in vitro laboratory data as well as animal studies. In these cases, we have tried several cell lines. This is the reason I am telling you, if you want to do studies in vitro, because of the heterogenic nature of cancer, you cannot just generate data with one cell line or 2 cell lines and then show, oh, this drug is going to work. The more we use, more cell lines we use, the more promise it's going to generate. So we have tested 5 cell lines initially, and then we tested that using cell viable tests for mitramycin to know what is the dose required to kill 50% cells, to determine IC50 values, we call it. And also we generated IC50 values same for vincristine as well. So this is one of the drug used for chemotherapy. So these are its IC50 values. And we also tried same thing for other chemotherapy, the etoposide, and then we generated dose curves. So these are the IC50 values. After that, we tried to do combination. When we tried in combination, for example, in vincristine and mitramycin, we used the doses which is killing not 70% or 80%, between 50 to 75, because about 60%. We are actually using doses less than IC50 values for mitramycin as well as vincristine. When we combine, the response is much more higher. That's what we need. So when we are seeing much more cell death, we need to see what is causing it, whether it is increasing apoptosis. So we measured apoptotic marker, CPAR. When PARP is cleaved, means there is a lot of apoptosis going on. When you see here in control, obviously there is no apoptosis, so this marker is not elevated. But using single drugs, there is some elevation. When it is combined, the elevation is higher. In housekeeping genes, the actin doesn't change much. So when it comes to FACS analysis, we have done flow cytometry just to see how many apoptotic cells are caused due to this treatment. Just by vincristine, it is, just in control, the apoptotic cells are like 10%. When mithramycin is used, they are about like 30%. When vincristine is given, like 26%. When it is combined, they are like 37%. So all these results show that the combination is much more better than single drug. Then we also tried in combination. When we tried control and also mithramycin and chemotherapeutic drug, and in combination, the tumor growth is completely gone. I've been working on cancer for several years. This kind of result I have never seen. When we injected, basically in this case, what we do is we injected cancer cells to the mouse. Once the cancer tumor is formed there, they're all human cancer cells. So we inject into the nude mice. So once the tumor is formed a little bit to this size almost, then we start treatment. So when the treatment is not given, tumors will go like this. When treatment, it's going to go down. This is a typical one. Even this is good enough to publish. However, when the combination is given, tumor did not grow at all. Not only that, out of like 7 mice we have treated, 4 of them, the tumor actually disappeared. So we only have tumor only in 3. So that is the reason we are struggling to publish. We need more data. We need more answers to do statistics. However, we have done data to some extent to show. So in summary, sometimes we need to be little bit think out of the box. If you only think okay, mithramycin or chemotherapy, we need to just think how about if you combine both. In this case, typically you should not have any toxic response because we are actually inhibiting. We are actually using low dose of both. We are reducing the dose of chemotherapy, and we are also reducing the dose of mithramycin. Because of this reason, we are not expecting any side effects. It should be even more, and it's funded by Wales. It's a grant mechanism. So there are some students, and she's a postdoc now, and these are the people who are involved in this study. Thank you.
Thank you, Dr. Basha.
I will be happy to take any questions.
Yeah, there are a few questions from the students. It was an exciting talk, and I think students could understand better this time because from last 3 sessions we are having talks on cancer. It started with Professor Manoj Mishra, and then yesterday it was Professor Upendra Manne, and today you are there. So I think the students would understand better because they are having the revision since last 2 days, and the topics were interlinked, though they were very different, but they were interlinked. So we have a question from one of our MSc students, Khushi. She has asked, want to know cancer in the light of evolution. Like you mentioned that cancer is as old as human life or more than 4000 BC ago. So can you speak something or can you tell in the light of evolution?
So I can just have a seminar on evolution of cancer. However, if you have an opportunity, look for the book. It's called An Emperor of All Melodies. That book is actually written by an Indian doctor actually in America. It got like lot of attention, and he got even Pulitzer Award. Pulitzer Award is like Nobel Prize in America. So it can give you, because initially it thought like, okay, the disease of age, no more it is age. And then it's called, disease of, impairment of immunity. It is not necessarily, because there's certain things. It's like when I was in India, I heard about a proverb, like 4 brain were trying to discover an elephant. Somebody found the trunk. They said, oh, the animal that has trunk is an elephant. Somebody said the tail. Oh, the animal that has tail is an elephant. Somebody is huge, leg. So if you combine everything, that's the elephant is. So same way, it's been coming like, when the evolution, if you try to see, the disease is there. And also, as I mentioned about Cancer Act also, people are knowing about it stage by stage. Initially, they know only about breast cancer because at that time there is no there are no tools actually. There's no imaging tools. There is nothing there at that time. Even if you see doctors in India, there are only one doctor who was taking care of people. Even MBBS were rare at that time. Now we have specialists, super specialists. So when it comes to evolution, the more knowledge we get, that's how we are actually changing our understanding. Okay, so this is not just because of this particular thing. So the more we know, sometimes it also confuses. Okay, what is actually happening? So that's the reason. If you ask anybody, what is actually causing cancer? Nobody can tell you exact answer because there are several reasons. Exposed, even if you see, in India, why cancer is getting more now? Because a lot of pollution. We will not maybe paying attention what is happening. That's what I mentioned about actually air pollution. Air pollution, one of the things we inhale, it's going to lungs, it's going to go into our body. We are inhaling something, some particles, foreign particles. You don't know what is in the particles. So just other thing, recently I believe you might have seen this story about Johnson & Johnson. They paid billions of dollars because the powder, baby powder, they use it for babies to control the moisture at private parts. That is a carcinogen that is causing cervical cancer. So all these things, when people are using it at the time, they don't know about it. Now we know about it. So during the evolution process, it is not like, that's why when I teach my medical students, I always say, when you go to anatomy physiology lab, how many human bodies you see? Do you see a body from 2000 BC or 200 BC and 18th century, 9th century? You only see one body. It's human body. That doesn't change. What is changing is our understanding. The more we know, the more we understand. During evolution process, if you want to say we evolved from monkeys, I'm not going to go there at the moment because again, science contradicts that. Because as a scientist, I need to believe on evolution. If you really think more and more about it, more than the evidence you get, you may also start to contradict that one. So why still monkeys are still monkeys and we are humans? So there are so many questions there. It's very difficult. So instead of we contradict, we argue. What we need to believe is what we know at this time. What we know at this time is mutations is the thing that's going to cause cancer. And if you look into the olden days, the people are not getting cancer. That is true, but maybe they are not diagnosed well. So, for example, my father's grandfather, he died due to stomach pain. We don't know. He might be having pancreatic cancer at that time. Who knows? It's not diagnosed at that time. So until we know, this is the reason we don't know if that is causing that particular disease or not. So I'm not talking about bodies, how they are evolved, but what I can talk about is during evolution, industrialization, several things are happening. So those are all causing this kind of people to get more and more mutations in the body that's going to cause cancer.
Yes.
But if you read that book, An Emperor of that book is going to give you lots of information about this. It's actually written in a layman language so that anybody can read it.
Okay. There is another question: why different types of cancers require different types of growth and spread?
Yes. So as I mentioned, because for example, if you look some certain cancers, they take several years, 30, 40 years even. For example, colorectal cancer. I have several slides. I did not, bring it, because I just changed my computer. I don't have my whole presentations here, where I can actually show. Even if you Google it, you can see how this colorectal cancer is going to originate. So you can see it. Initially, it takes years and years because in each stage, certain markers or certain genes are gonna are responsible for that stage to move on from non-malignant to malignant. So to move that one, it takes like at least 20 years, 30 years in some cases. Once the tumor is formed, then it is very quick. It's going to become cancer, and also it's going to start to metastasize. It's going to move on to liver first and then lungs and all those things. So when it comes to because of that reason, for example, pancreatic cancer. So it is one of the toughest cancer. People are dying more and more with pancreatic cancer. Maybe like in 30, 40 years, it may become number one, even depending on how many people are diagnosed. Maybe same number of people are going to die every year. So the different cancer. So depending on what is causing that cancer. So, and also what organ, how vital it is. In pancreatic cancer, the problem is liver is next to it. It's going to really spread very quickly into liver. So, for example, Steve Jobs, everybody might have known about Apple, founder, one of the founder. He got pancreatic cancer. He died due to liver failure because he went for liver transplantation and then eventually he died. So many people are going to die like that because the cancer. And I also know one of my friend's wife. She got like a TNBC, triple negative breast cancer. Whatever the reason, they just delayed without. They are indicated, but still, unfortunately, they did not pay attention to it. She got headache. Then she went to check for that one. They found some tumor in brain, but the doctor thought it doesn't look like brain tumor. It is coming from somewhere else. After examination, they found out she actually had TNBC, triple negative breast cancer. That spread to bone, that spread to liver, that spread to lung, and also spread to brain. So she is at advanced stage. She could not survive. So it all, it depends. Certain cancers spreads very quickly. Certain cancers, they don't spread quickly. They are slow poison kind of thing. For example, prostate cancer. It is very slow cancer. People say, okay, if you are diagnosed with prostate cancer, don't take any treatment. Maybe by the time, for example, you are diagnosed with 60 years, you are going to die after 20 years. Anyway, you are going to die 20 years. So why you want to, risk yourself getting a lot of treatment and a lot of radiation? So certain cancers are going to grow slowly, but certain are very quick. So it all depends on what is causing that particular cancer and what is the area that's affected. What are the vital organs? If it is affected liver and something, it's very difficult to treat. Liver cancer is also growing very, very well now. So a lot of people are getting liver cancer, and it's cancer unless it is affecting reproductive organs. It's not going to affect cancer. They may not have babies. That is the reason it can induce sterility. Because of that reason, they want to have these banks active. They collect and they save it. So chemotherapy is definitely going to affect it.
There are many questions in queue, but I'll just take one or two, and I'll take your permission. If you allow me, I'll ask the students to write on your email. They can send, because the list is endless, right? So I'll just take two more questions, and then I'll ask them to write, right? So the second last is, does epigenetics play a role in cancer?
Definitely, yeah. Epigenetics actually is going to care cancers. Most of the cancers, epigenetics is a big role, and also the treatment options also now focusing on modulating epigenetic mechanisms. I actually work on a specific protein transcription factor that was target of my therapeutic options. So that also has lot of role in epigenetics. So epigenetics is a very popular area and a highly relevant area for cancer.
The last one which I'll take for today is, any possibility of cancer preventive vaccines in near future?
So HPV is only the preventive vaccine so far we have. That is gonna save, that's gonna prevent infection-related cancers, related to that particular one. I don't want to go into details. You can Google and look into it. When it comes to regular vaccines, they do have several vaccines. They are actually now, I'm aware actually of one of the clinical trials that person came and presented to us. The current vaccines are actually used in therapy and also to prevent relapse. In the disease I mentioned about, this is very aggressive disease. So what the new mechanism, what they're trying is to take the tumor at the time of surgery, when surgically the tumor is removed, they take some tumor piece from that one, and they develop a vaccine using that tumor, because it's a immune response they are going to generate in laboratory. So they will inject it back to the patient. It's actually patient by patient. It's not like a single vaccine they have ready. but they prepare to that particular person using the immune response from the tumor. So that is given back to the patient so that it's going to help them to prevent a relapse, because in immune sarcoma, relapse is very common. That's going to kill patients. So I know a patient who took this vaccine. She's been surviving. Typically, the lifespan is not more than 5 years for many patients, but she's surviving almost like 8 years. Not 8 years, actually, I am here 8 years in this institution. But she, when I joined, she already took that vaccine. So she might be surviving 10 years now. She got actually relapse, but it was not that much high. It was surgically resectable. So the vaccines right now in trials now is not like a flu vaccine. You take it, you don't get it. It's not like that, because vaccines can only work on immune response. Until now, to prevent cancer using immune response is not fully studied. So the immunotherapy, whatever is under testing, is not very specific, like using like checkpoint inhibitors, those kind of stuff, how cancer cells are escaping from immune mechanism. That's what the immune therapy is focused on. It is not like something you can completely stop it, because it's not an infectious disease where you can use vaccine so that you can stop it. So that is the limitation with that one. All vaccines are basically on therapeutic process, not necessarily a preventive process. HPV, because it's through infection, that is the reason that's a real vaccine to stop HPV-related cancers.
Yeah. So the students really liked your talk, and the response, there's a huge response, and still they are going to bug you up with the questions, as you have
No
said.
problem. I can even stay longer to answer questions, because when I gave seminar to Mizoram University, typically I don't want to go more than 1 hour. I only give like 55 minutes. Then the questions were like 2.5 hours. So I stayed 3.5 hours. So I don't mind staying to answer questions, because
no, but
I mean, I don't have much knowledge. I also have limited knowledge. Whatever I know, I can tell you. If I don't know, I will say I don't know. That's not a problem with that.
We could have extended for long, but I know it's very late at your end. We have started the day, but
we are only 12:15. My time is until 2:30 a.m. I am fine. I always go to bed like 2 a.m. So it's not early for me, and I don't mind staying even answering questions. But if you want to, I'm fine. Either way is fine.
No, we'll just write on your email. Right.
You have my email, you can share with them.
I'll share with the students.
Anything that I can even refer to the people who can even better answer.
That will be good. And now I hand over the mic to our head of the department, Professor Sudhir Kumar, for vote of thanks.
Thank you.
Thanks, Dr. Basha, for this involving lecture. There's raised many questions from the students, and you are kind enough to satisfy their query. Actually, you mentioned this having sarcoma. It is a rare disease, but now it is. Do you feel, it's my query, that do this disease has some racial basis also, because it is more prevalent in the white population or the European population than the African or Asian population?
So when it comes to Ewing sarcoma, because already the numbers are very low, I'm not seeing any relevance with regard to disparities. One of the reasons is in developed countries, the diagnosis is very high. For example, in African countries and other places, it is not reported. It doesn't mean they don't have it. It's a bone and soft tissue cancer. So I'm not sure is there a racial disparity about this disease, because already if you have like low numbers, it's very difficult to tell. It's only confined to certain areas, certain people.
Okay.
But it doesn't here. We see it among whites and African Americans. Again, we have to do it number of ratio also. How many people are there? For example, if you have like 100,000 population, in 100,000 population, how many Hispanics are there? How many Caucasians are there? So if you look into the proportionate wise, so far I'm not seeing any much disparity when it comes to Ewing sarcoma.
You mentioned very much interesting thing, that some vaccine is developed against this cancer.
Mhm.
Do you
Yes.
know any other case where this vaccine is developed in any other type of cancer, like this colorectal cancer or some lung cancer or so?
I mean, there are certain cancers working on for prostate and other things. Prostate cancer also, I know there are some clinical trials going on that one. So the major limitation is, again, how you manipulate this immune system.
Yeah.
Because because as I mentioned, each cancer has heterogeneity. Because of heterogeneity, it has subgroups and all this. Because of all these reasons, it's getting little difficult to come up with a single vaccine that can address that can actually treat or do this one. So that is the reason actually this immune sarcoma was very successful. One of the reason is, even though it's a time consuming, and it is because that is possible because of immune sarcoma type itself, because there are not many patients getting this disease. If, for example, if same strategy has to follow for prostate cancer or breast cancer, it's going to be a little difficult because you have so many patients there. So taking from each patient's sample and then prepare some kind of generating laboratory like immune response and prepare, because it's person to person. It's not like you develop one and give it to everybody. So because of those limitations.
Why I mentioned this specifically, because there is a frequency of relapse in case of oral cancer, which is most prevalent now in India because of the chewing tobacco, various use of tobacco. So can we intervene through this some vaccine in the relapse of the oral cancer? Is there any possibility, from as you are a specialist in that area?
No, I'm not a specialist in oral cancer, but again, the limitation is again
the vaccination.
But yeah, no, I'm not an immunologist. I am actually, I'm also from zoology. My PhD is in zoology.
Ah, great.
Yes. Then
I thinking that you are the medical person.
No, I'm not a medical person. I am PhD in zoology. Then I came to College of Pharmacy in Rhode Island as a postdoc. Then I went to MD Anderson as a faculty, and then I came here as a faculty. But I am actually in. That's what I always say. I'm a research professor in medical school. I always introduce like that, because when I look into my department, I also get calls. Can you see my child, because I'm in pediatrics? I said, sorry, I can't see your child.
There's a problem in medical college.
So it's a medical school, but I'm not a medical doctor. Medical person.
Yes, good. It's a matter of satisfaction that a zoologist is there in the medical college, so it's a matter of
there are so many people. Zoology is a basic science, right?
So thank you again. After this, we are very much pleased to have you here, and I hope that whenever you visit India, my standing invitation for you, because of this COVID and all these problems, we are celebrating it, or we have organized this online, but initially we thought that up to that time we could invite at the department, but you are most welcome whenever you visit India to see our department, to interact our faculty and students. Thank you much. We have spoiled your this Sunday night, but even then, the talk was nice. Thank you.
Thank you. No problem.
Good night.
Good night.
Good dreams.
Yeah. Good to see you. Bye.